What's up, Sam? How's it going?
It's good, Mike. It's good to see Thanksgiving holiday coming up. Getting into the a busy season of jaw surgery. Are you full for the rest of the year?
I pretty much am. We had to reschedule a TMJR due to the devices not being quite ready, though. So we may have a little bit of open time, but not a lot. What
Definitely
about you?
frustrating. That part of fabricating fabricating devices are definitely prone to delay for a number of reasons. So one day that'll be better.
Yeah, I mean, it's already gotten better. So
Yeah,
hopefully
I
it'll
agree.
continue. What do
Um,
you want to talk about today? And do mandibular fixation? Is that what we were kicking around?
yeah, I think we were talking around different ideas and fixating a sagittal osteotomy sounds like a good one.
Okay.
Because I think I have a different approach than you do.
Probably. What do you go? How do you go about it? You got any images you can show us?
I have some images, but not like a crazy PowerPoint. But generally, I think um, there's plate fixation and then screw fixation. I think there's different camps on that, like positional screw fixation, um, using a lateral plate, using two lateral plates, using lag screws. Have you ever done that for a sag?
I have never actually done lag screws that
Or
I
lag screw technique, I think is more formally correct. Um, because at least I know of people that are doing all those different techniques, and so kind of talking about that would be interesting because I I think that all of those have their role, and so kind of understanding the pros and cons of them is a good topic.
you know people who are actually doing lag screws, not just positional screws.
So the screw itself doesn't, it's not missing threads in the middle area. It's just
Right.
that they're using the technique of lag screw, like outer of the proximal segment is over drilled and it engages the distal segment in a compressive way.
Hmm.
Um, I know that sounds crazy.
Now that you say that, I think I remember watching a video of Tucker doing that. Is that who you, is it that group that you know doing it, or was it him that was doing it, or other people?
Well, in terms of people that I've learned from, I think I've learned from Tucker that same technique. I think in terms of lag screw technique, the concern has always been condylar change, right? So the compression of the two segments influences the position of the condyle, right?
Yeah, that torquing in the condyle and also just maybe even over compression of the segments with relation to the nerve in some aspects.
Yeah. I mean, I think when it comes to the different reasons why people use the different fixations, I don't know, I would say fixation of mandibles more so than other things. People are very strongly in one camp or the other. I feel like I'm a little atypical on that. I'm pretty open to both ideas. Um, you're pretty strongly in the positional screw.
No, I use both. I was mostly trained with positional screws though.
I was the same. I would if I was in a camp, I would say I'm in the plate camp more than the positional screw camp. But I use both.
Do you think that is from your practice also dealing with TMJ surgery, or is there other reasons for that?
Nah, I think there's probably other reasons that um in terms of training, so training, I learned a lot on positional screw fixation, whether using a trocar or doing transoral. In fellowship, we used a trocar and it was positional screw largely. But one of the big differences I noticed once I got out of fellowship is I had a lot less seasoned hands around me. So I had my assistant, there wasn't necessarily another surgeon helping me out, and having um, maybe people who had less experience assisting or absolute less people assisting. So if you only had one person helping you out and that one person is a relatively new operation for them, I found positional screw to be technically hard to carry out. I found that to be a difficult task to hold the proximal segment, the trocar, and drill. I felt like I needed one extra hand for that.
Hmm.
I know the solution exists for clamping the two segments together. Um, but the possibility of injuring the lingual nerve always freaked me out, and the possibility of changing the orientation of the proximal segment with the clamp freaked me out. And there's while it may not be every time is a problem, I know for sure there's times where if I clamped the superior aspect of the ramus. So for people who may not have heard of that technique, this is putting a bone clamp on the superior aspect of the proximal and distal segments. So to stabilize the proximal segment, so you can then provide positional screw fixation. But you know, I think it can change the position of the proximal segment. So I just found that technically challenging to carry out with only my two hands. So I switched over to plates and screws out of necessity, really. Because I feel like you could do plates and screws if it's just you and like a more junior person. So how'd you end up on plates?
Yeah, I mean, I've kind of had a similar pathway. You know, you hear and you read all these things about how positional screws potentially are going to torque the condyle. You know, if you have to remove them, you then are going back through your extra oral incision, all these kind of things that, you know, some people subscribe to them being of significance and other people view them as minimally significant. I preferred plates when I first got out for similar reasons because I didn't have hands, for one reason. I also feel like to an extent, you know, when you're trying to do positional screws without a lot of hands, or even sometimes when you have hands, your technique is basically to position the proximal segment and then use the trocar to shove it, you know, against the distal segment. And if you know, you may have some interferences, which then can cause issues. You may compress the nerve, which may cause some issues. You may not really be passively seating that just because you're trying to, with only two hands, seat and compress, and you're just kind of shoving the hell out of that against it. So I wasn't always convinced that that was the best technique. So then I tried to do plates, which, you know, have its own pluses and minuses. And then I kind of went back to screws, and then I tried the clamp, kind of like you said, which I think at times I've used the Wolford clamp. You know, I'm familiar with, like, I think a Van Sickles clamp, and I think there's a Wolford clamp. There's probably more. But the Wolford one I found is maybe a little bit better. I don't know that I have a picture of it. It's not like if I remember correctly, the Van Sickles one is more like just like a coker that's just kind of adapted in a way where you can clamp the segments together. And
It's
the
the same
Wolford,
premise though, right?
yeah, yeah. I mean, I think if everything's completely passive, you're not doing asymmetry. The first point of contact, you know, comes into play, as I think you and I have talked about before. You know, I think it can have a role, even if it's putting it on there to just hold it at times when maybe it helps you get your plate most of the way there, or whatever it is to assist you. I've used it at some times and found it useful. And then I feel like I'll try it in some instances thinking that it's going to be helpful and it's not, and makes things worse.
Yeah,
So
well let me see if I can share my screen, because I just pulled up a kind of generic jaw surgery, just a, you know, not a crazy class 2, little bit of asymmetry associated with it. And so if anyone's actually watching this, the different fixation techniques that we've been talking about is positional screw of some variety. Um, you know, people generally place them above the nerve, but I have seen them and I have done it to where they run out of room and you put another screw in low, or a plate. And the typical plate position is in this area, a single mandibular plate. I've seen also mandibular plate in this way, in this T configuration. Of course, there's dual mandibular plates. Um, and this is independent of custom or non-custom, but plate fixation is, you know, plating the Dalpont versus positional screw fixation is what we've been talking about.
yeah, have you ever used those adjustable plates?
No,
No. I say
I know
I've
what you're
always
talking about
tried.
though.
What's that?
Yeah, so I think I can kind of draw that. So those, and I forget what company has it. Is it Synthes?
I don't remember. I remember asking a different company about them, and they said they didn't have those exact ones.
There's something like a circle to it, and then you put a screw in the circle, and then when you tie, you put it in the distal segment, like you put some screws in the distal segment, and then as you push the condyle back, that tightens the washer to the movable plate. It's something of that nature. I just feel like there's too many moving parts when it comes to that.
Yeah, I think I have a friend who trained at Kentucky, and he said that that's what Van Sickles does, is he
Sure.
puts that on, fixates it, I think puts on positional screws after that, and then leaves that plate on and positional screws on.
Yeah, so independent of all the other reasons why people choose positional screw or plate fixation, I think truly a number one should be is which one can you get fixation of the mandible with, right? Like which one can you carry the surgery out with? And for me, it was because there's a retractor, right? So there's I have a toe out here. I can use the toe out to hold the proximal segment back and superior, and then I can feel interferences, and it allows my right hand to drill a hole and then drill a second hole, and then I can seat the proximal segment and place the two distal holes, right?
So
Um,
what you're saying is you bending and adapting your plate, and then you're drilling two screw holes with the plate in or with the plate out.
because without a ton of assistance, you can carry out that task transorally, right? Like,
Mhm.
so, I grab a plate and bend it, right? After interferences are managed. And then if the plate looks like everything's in good shape, I'll drill, like I'll just mark the bone and then I'll rotate the proximal segment up so I can go from inside the mouth and then just drill this completely, put the plate in. Um, tighten that screw down, check the orientation of the plate, and then put my second screw in, again with the proximal segment rotated up. And then I can seat the proximal segment and then put in this screw, and then lastly, the last screw.
Got
And I
it.
feel like you can have relatively minimal assistance and pull that task off. What do you think? Is that
Yeah, I mean, I may give it a try because yeah, sometimes I don't have as many hands as I would like. With hands, it makes things easier, and that's where I actually think if you can remove interferences and you're pretty confident about it, I think that positional screws are easier, even with less hands. Because once you get that first screw in, like
from
you're,
that point forward is easy?
yeah. So that's kind of what I do a lot of times. I feel like if I'm worried about interferences, if I'm worried about, if I have some reason this doesn't come up often to be too worried about TMJ issues, and I think maybe I might torque it, or then I'll do a plate first and add screws. But I think typically I most recently have been kind of putting in a screw or two and then putting a plate on afterwards. And I think you do plate first and then screws, right?
Yeah, like nowadays I tend to add a screw in largely because I mean the other reason why I like plate is I think it's a little bit more friendly to nerve, largely because your plate bending is imperfect, right? So um, largely it's going to be imperfect in a way that's going to separate the bone slightly, which is good for the nerve, but maybe not so good from the bone healing perspective. And then from the location of the plate, I think it's just easier for it to have hardware trouble like infection. Um, and if you're questioning or if you're managing an infected plate and that's your only sort of source of fixation, it kind of stresses me out a bit. And so I'm definitely trending towards a single screw superiorly with a plate in any advancement.
You gotta put
I
in at
think I've
least
been on
two.
that for a number of years, actually.
Put in at least two, man.
Yeah, if I didn't have a plate, I mean, putting in more screws makes sense. But I think the nice thing is you can get a lot of fixation by separating the two sources of it. You're bringing up a
Yeah, this is basically what I try to do most of the time.
Yeah, because I mean, this topic, like any other with jaw surgery, gets complicated quickly. And so, like, you're bringing up a picture of wisdom, like a case where you took out wisdom teeth at the same time.
Yep.
The age of the patient, the fact that their state of their joint, those are all kind of different considerations in these. But um, the wisdom teeth complicates fixations in both ways, I think, because with the plate, um, that proximal most screw on your X-ray can be in really thin bone, right? Because that's where the impacted wisdom tooth was, and in a young person, it could be really like poor thin bone, right?
Yep.
Um, and those superior at the same time, those superior screws, with wisdom teeth in, you're a little bit more prone to having a lingual plate fracture if you're going to have a bad split, in which case your positional screws may not be providing any stability in the mandible at all there.
Yeah,
But
or drilling them, replacing them may lead to that.
exactly, it can weaken it because obviously you have to drill a hole, and that weakens the bone as well. And so I do like the combination what you threw down there, except you have two screws, which is a little excessive. Um, but I think the combo, like it hedges your bets on the two things, right? Like
Yeah.
it covers your bases so that you get it to heal. That's um anyway, I think the combo makes sense. But I think the thing underlying mandibular fixation is interference management. So things like condylar position change, or um, nerve injury with fixation type. I think all of that has to do with interference management. And so while people talk about fixation, what they're really talking about a lot of times is interference management. Um, and I definitely find there's a feel to that.
Yeah, I mean, I think interferences is the key. And it's, you talk to people and you teach residents and you interact with people who do this. And I mean, I'm still amazed that there is a good number of people who just make the cut and pretty much just shove things together and
Oh
fixate.
yeah.
And don't even think that that's a problem. And it makes me wonder, like, well, is it? Like, am I overthinking it? Am I taking time removing interferences and doing these things, and I'm just wasting time? But I've had issues when I feel like I've had interferences. I think you kind of have to have these things sitting fairly passive together.
Yeah, here you go. Let me do a little sharing of a screen.
You're gonna
It's
share,
one
or
that I have up. You gotta unshare, and then this one is not like the best example, but it's an okay example of interference, right? So this is a little bit of an asymmetric class two correction. So there's a little bit of yaw. And so on the right side, there's largely no interference, right? So if we make things translucent, there's this should feel pretty passive, right? So the typical interference is when the mandible advances, it's right here, right? So as the taper of the mandible advances, it's in that spot, but it's really all along the proximal aspect of the distal segment. But on this left side is where things interfere, right? So you can kind of see at the very superior aspect, those bones are running into each other. And this is certainly an issue when you do more complicated things like really dramatic asymmetries, or if you're widening the mandible at the same time as advancing the mandible. Um, like those sort of things, management of this interference, because what ends up happening is you have one segment that you feel like is probably okay, but it's hitting this interference first, right? And then um maybe it's not that dramatic, but if you hit the superior aspect, like the bone where it touches first up here, then the angles can be off, right? Like the left angle can be wider than the right angle. I think at this point, if you shove the bones together, is where condylar change or where nerve squishing occurs. Um, because there's a nerve between these two bones. It may not necessarily be where the bone's hitting, but it might be. Um, and so management of those, I think it is a trick. I think like a lot of this stuff, it tends to be um, a bit of a feel thing. I remember learning mandibular osteotomies, and like you can understand the concept, you understand the steps, but it takes a while to really understand the feel. Um, and that there's definitely that when it comes to mandibular surgery.
Yeah. So
Um,
do you subscribe to the theory that you're kind of classically taught in the textbooks and in training that positional screws, or I guess, mostly we were taught lag screws, but positional screws or lag screws do torque the TMJ, the condylar head, and have you seen negative repercussions that you would attribute to that? Do you think that's a theoretical thing, or do you think that's a real thing?
well, because and I don't want to name people, but I mean the um, I think the lag screw technique provides good fixation, right? Like it does a good job of squeezing the bones together. If you manage interference, so that the nerve isn't being squished, that the proximal segment is in the correct spot, I don't think there's anything wrong with the fixation technique. I mean, because
Yeah.
that's the argument for it, right? Like it's the best way to hold bones together. All else being equal. So if you manage interference so that the nerve isn't being pinched and the condyle is not going to be lateralized, what the technique itself shouldn't matter that much, which I don't know. I totally think is true. It's just I'm unclear if the interferences are being managed by many people, you know?
Yeah, I agree. I've been really surprised by that, throughout my career about how minimal interference removal is. And I mean, I've heard strange things too. I mean, maybe they're not strange. I mean, who's to say who's right and wrong? But like people have fear of removing like the cancellous bone from the proximal segment because they think it hurts blood supply. Have you ever heard that one?
Well, yeah, no, I mean like dissection of the ramus for blood supply and
The dissection,
removing
yeah, stripping the periosteum and
bone.
all that. I've heard. I mean, but like, you move cancellous bone from the proximal segment to remove interferences. And I've heard that one recently that there's fear of that compromising blood supply by removing the bone from the proximal segment.
Well,
Yeah,
so the end result of compromising blood supply would be difficulty with union.
I would guess, I mean, I think you'd worry about what necrosis, hardware failure, non-union, malunion. But I mean, it doesn't bleed when you do that. Like was my kind of counterpoint. Like when you're moving cancellous bone from the proximal segment, it's not like causing a big bloody mess. So I don't know that you're getting it.
Yeah, I mean, I just wonder how much you're kind of I mean, it's somewhat what we're talking about now. It's like it's easy to overthink things, right? To
Absolutely.
um, I bet you we're guilty of that somewhat in this, but in terms of the fixation process, I think considering the nerve, considering the condyle, considering the fact that the patient needs to heal are all good considerations. Because I mean,
Yeah.
honestly, if I went back to my fellowship, I'd probably be just fine putting screws in all the time. If it was me and Farrell operating, I mean, you know what I mean? It's like
You
two
have
people
another, if you have
speaking
another
the same
surgeon
version.
with you at all times, is what you're saying.
Well, no, because um, I think it depends, right? Because I bet you, from Farrell's perspective, if he was watching me as a fellow and thinking about starting up plate fixation, right? Like it kind of depends on the person who's helping you out and is able to do it. And I think when you get out of those situations and you're doing it on your own, or even if you're doing it with the senior person, um, you want to be able to provide the fixation that you're convinced is going to heal the bone and you're most comfortable with. I just I'm still of the camp. It's plates most of the time. Plates are the main trick with plates is learn how to bend them.
Yeah, absolutely.
Well,
That that's the tricky part that sometimes people don't like when
but it
they're
isn't complicated. It's like the
yeah.
Dirk's zygoma plate bending tips. I don't know if you saw his. That's an older paper, but because it's either stepping up or stepping down. It's unusual. Generally on MMAWs, they're straight. Um, have we talked about this? Like the plates stepping up or stepping down?
I don't know that we've talked about it on here.
Oh, yeah. I mean,
Give us a brief rundown.
here I'll use this generic thing again. Um, but with the mandible going forward, typically the distal segment is going to be um wider than the proximal segment.
Right.
And I know this isn't true because of this proximal segment being flared out on this left side, But on the right side, I know it's not dramatic, but generally speaking, for this case, during surgery, because of the lack of contact, you're probably going to have that tip in a little. And so you're going to go to first point of contact and it's going to have this step, right?
Mhm.
So when it comes to things I use the 3D plan for, one of those is kind of eyeballing this step, right? So I know that this proximal segment is as good a position as I can make it if the step looks pretty similar to my plan. And when it comes to advancement, it's stepping up. So there's kind of this step up bend. And
Yep.
you can look at that and say, hey, that's 2 millimeters or 4 millimeters, very much like bending a maxillary plate. And then there's a bit of a twist to the last hole. Depends a little bit on where you put your dowel pont. Like for whatever reason, my engineer designed me to make a cut where you make cuts instead of my big anterior dowel pont location. But anyway, the mandible tends to twist down a little, so the back one I just flatten. And the opposite is true for setbacks. So setbacks, you have to just step down because the proximal segment will be a little bit wider than the distal segment. Uh, I don't know. I think the bending of plate that generally gets it close because that's what freaked me about plate fixation. Honestly, it's where I spent a lot of my time until I kind of figured out the cheats in plate bending. But now, I mean, plate bending isn't a very
That's
long thing at all.
Yeah, I think that's the tricky part if you're trying to, I think the technique that you described makes it a little bit easier in the sense of like how you do your screws and whatnot. But yeah, I think that's where I struggled when I first got out and when I first got out and was trying to do plates when I was mostly trained with screws. That was the tough part. Is like you'd bend it and you'd get it 90% there and then, probably should in hindsight, kind of do how you did it or drill my holes and then have it fixated to the proximal segment, pull that out, and then I could, in theory, bend those other two screw, like the other half after it's already fixated to the proximal segment, or
Yeah, like bending the plate while it's attached to the proximal segment. I just generally found that to be
it's not easy and it's
not accurate. Yeah, I mean
yeah,
it's hard to get the benders in there and
yeah,
but generally you can get it, like 80+%. And in what way is it bending correctly? It generally caused the proximal segment to be a little bit wider than what you wanted it to
yeah,
be,
yeah.
which in a lot of cases is fine. But in some cases isn't, right? Like, I mean, if you're working on narrowing the mandible or really
I think
concerned
that's
about
where it bothered me is because that's exactly what would happen is when I was first doing it is I would put it on there and it would separate. And maybe now having years more experience, I don't know why it bothered me. I don't know if it was just a type A personality of like, okay, there's some separation, or if it was truly like I'm worried about this may not heal as well. But that what you just described is exactly kind of what my struggle was when I first got out on my own, didn't have hands and was trying to do plates. Is like I feel like it would pull often the proximal segment away.
because that first screw in the distal segment is like the crucial one, right? Like,
Mhm.
um, and having the team on board to where you can drill and then place the screw quickly is difficult.
Yeah.
I mean,
Oh man. I harp on that all the time of like that's when I try to work with people all the time, I'm like, I shouldn't have to tell you what the next thing is every time. If we're using a blade or a bovie, we're probably going to need the periosteal.
yeah, because I mean,
Drilling a screw, we're going to need a screw hole, we're going to need a screw next. And, if we're
I think
suturing, we're going to need scissors and, stuff like that you're saying is,
I agree. I mean, in the perfect world, you always have everyone in the room who you're used to doing it with, and you've done it a million times. But
right,
in reality, there's stuff that comes up, right? Like
never going to be that good. Yeah.
just life happens, right? So you kind of need to be flexible and need to adjust to it. And like the thing with trocars that I had trouble with was the trocars that they had at my hospital were different than the ones that I had trained in. Like they were using the inner drill guide that then the trocar would move in relation to the guide. And so if I was holding the proximal segment with the trocar, then I took out the drill guide, then it would move, right?
Yep.
And I know they have different designs and whatnot, but just like, you know what I mean? Like the access to that. If you only have one trocar that you use and then whatever it drops on the ground or it's not sterilized correctly, then you got to come up with a plan B. And
Like reading my
that's just
mind.
the reality of practice, right?
Yeah, I went through that same thing recently with the company that I use of like, there's one drill, I can't remember if it's the length or something that requires the drill guide and another one that doesn't. And so they would sometimes have one where I would have to use a drill guide. And then as you're saying, like you're trying to drill while you're holding this segment, take out the drill, put it on safe or hand it to somebody who's usually not waiting to hand it, to receive it. So you're like throwing it on the patient or, putting it down, then using your other hand to unscrew a drill guide and then take a driver and put it through and screw it in all without it not moving either the segment or the trocar from your screw hole or from your drill alignment. And it just,
Yeah, I just remember anyway, like
oh,
there's stressors and training, and one of those I had an attending that would primarily communicate through yelling. And
so
man,
that's
it
where you
was
picked up
definitely
that
like a
habit.
point of stress to not move the proximal segment. I'm like, just don't move. Whatever I do, I gotta hold this thing together. And of course it would move, or you know what I mean?
Right.
Like, because
Well, I
it's
mean, that can be an actual problem. I mean, you can
yeah,
burn
totally.
up your screw hole or your bone for screws and where you try to drill a new one and it widens that one to where now your screw doesn't fit, or now
Yeah.
you're carving up the fragment, you get a lingual plate fracture. I mean,
Yeah. So I mean, trying to because obviously getting your fixation the first time's the best because the second go round, you're gonna have more holes in the mandible. It's all it's gonna do is weaken it. Um, so yeah, so I mean, I think that in terms of fixation, a lot of my setbacks these days are just plates. Almost all my advancements are a plate and a single screw. I can be talked into two screws every once in a while. I test the mandible to see how much play is in it to make the decision. I think the plating company, the plate tech, the types of plates make an impact. I think the amount of advancement makes an impact. How much I trust the patient to not chew makes an impact. Um, I know
yeah,
those shouldn't, but they really do, right? Like,
no doubt.
because
Yeah, I mean, I try to, as a general rule, try to control as much as I can and remove those variables. And so that's why I kind of am a plate and two screw guy. Like, I mean, I
yeah,
want that
I mean, if
thing
you do both, I
solidly
mean,
fixated.
honestly, I don't think there's not a good argument to made other than you're wasting two screws a case, and that's not that much money in the overall picture. I mean, um, plate and four screws is more expensive than two or three screws, obviously.
Yeah,
Um,
no
and
doubt.
so if you're placing six screws on a side versus three screws on a side, there's more cost. But I mean that's a relatively small difference in relation to the overall picture, and then also like the normal discussion, which is custom plates or not. Custom plates and mandible. I'm not sure on here if we talked about custom fixation, but I generally think custom plates in the mandible are silly. Like, are you on board with that? On the sagittal osteotomy.
I'm not sure I've ever used them, to be honest, to have an opinion from experience to say that I've used them and there was a benefit or not, or any of that.
Yeah, I mean,
What are you just saying there? You feel like they're unnecessary, or you feel like they're not adding any quality to the fixation?
because it would be plate fixation. There's not custom screw fixation,
Right.
and so it'd be a plate fixation. It'd be customized to your plan, which again is very dependent on you getting rid of interferences, but additionally is dependent on you planning them in the correct condyle position. Um, and what that would entail is your assistants who are getting the X-ray and getting the scan of the teeth need to have their mandible in centric relation. Um, and obviously you can carry that out sometimes, but I don't think you can carry that every time. So if the condyle isn't seated in the records, then your result will be different than your planned result on the Dalpont. It
Yeah.
won't make a difference on the teeth, but it'll make a difference. It won't make a difference on the distal segment mandible, the chin, and the mandibular body will all be the same. Just where the proximal segment will be different than your plan. That one throws patients off, I find too, by the way. Like, have you had
You,
patients?
have you done that? Have you
What's
used
that?
that? Have you tried custom plates in the mandible, like you're saying?
Only for inverted L's and Z's and those sort of things. For Sag, I just don't know why I would order it at all because I just can't oversee getting records. So I've done revision cases where there's custom hardware in there. So I think I don't know. I fail to understand in the mandible. And I mean, I know people who use custom hardware with high frequency or with relatively high frequency, and then it doesn't seem like in the mandibles use that frequently. But I'd be open to alternative opinions if people can make a good case.
That may not be a bad topic for another show. If you know people who are using it routinely, maybe get some
In the
guests on
maxilla
here.
to get them on.
Yeah, I mean, yeah,
Yeah.
the maxilla, I know more that do it in the maxilla too, but if we knew anyone or could find anyone who does it in the mandible or both, I mean, just a decent topic to discuss.
Yeah, I think it's a good one. I mean, definitely our future meetings. So we had a scheduling snafu today, but future ones will have another person or two on them to float out other ideas. Because I think there's a truth in different opinions, right? So like hearing other people's
Are you a believer in that these custom fixation hardware allows you to do double jaw cases in an hour?
no
Huh. There would be
for
some people who would
the
argue.
same reasons that I don't know. Anyway, like if you don't care about interferences and if you don't care about nerves, I mean, just because interference management, independent of splitting the mandible and opening and closing the gingiva, interference management can slow you down. And I think it's time well spent. There's go slows and go fast is what I was taught. There's go fast part of the operation and go slow. And there's times to go slow and just it's fine, right? Spending a bit more time, like absolute time. I think we both know very senior or now retired surgeons who did huge volume and also, like as experienced as people can be.
Yeah.
I don't want to speak for them, but they're surprised by the idea of doing a two jaw in under an hour. And I don't think it's fixation related. So I think that's a discussion for another day. But I think generally the custom fixation mandible requires absolutely solid proximal segment, which is largely going to be class 3 situation, which oftentimes class 3 plates are easy.
Yeah.
Class
Yeah.
3 screws are hard though.
Yeah.
You don't think
Maybe
so?
for you. No, they can be for sure.
Uh,
They can be, but I mean, you do both.
yeah, it's true.
You choose the easier one first, and then if you need to do the other one, you do the other one. That's how
Yeah.
I've kind of gone about it recently. But all right,
Yeah.
well, till next week. Are we gonna try to do this next week?
I think so. Next week is December. So happy Turkey Day. Are you cooking in Arkansas?
Not if anyone wants to eat.
We just got electricity back. There's a big windstorm and we hadn't bought any of our turkey stuff because we were entertaining going somewhere else. But now that we have electricity, I can cook. So
Nice.
I'll send you some pictures of the turkey.
All right, sounds good. Well, see you next week.
All right, man.
Yeah.
Good seeing you.